Have you ever had severe bleeding to the point you could not go to school or work? I want to help you understand some of the causes and discover how to treat heavy bleeding so you can live a full life again. Welcome to Women's Healthcare Answers, and this is Jeff McQueary, a Tennessee gynecologist. I want to focus on you, especially if your gynecologic problems are dominating your life and you want to take back control. You can solve your problems with answers and solutions I will give you. The problem we are dealing with today is those dreaded heavy periods that can truly dominate your life. Sometimes you can feel you are bleeding to death. Well, let Women's Healthcare Answers solve this problem for you, and watch till the end to know how I solve heavy bleeding problems for my patients. The technical term for heavy bleeding is abnormal uterine bleeding, and it accounts for 70% of all gynecology visits, especially for women in the perimenopausal years. In order to understand what abnormal is, you need to know what normal is. So a normal duration of your periods is approximately 5 days. And cycling between them is typically between 21 and 35 days, but varies between each period and can vary between women. So what is abnormal? You may read terms such as menorrhagia, metrorrhagia, polymenorrhea, or oligomenorrhea. Well, let's define those. So menorrhagia is heavy bleeding, more than a third of a cup, which is also about 80 milliliters, and this is during your whole cycle. But it truly is more based upon your perception of what seems to be heavy for you, because we typically really don't measure it. What is metrorrhagia? It's bleeding between periods. Polymenorrhea is bleeding more frequently than every 21 days, just way too often. Oligomenorrhea is bleeding less frequently than every 35 days. And it's when it leaves you wondering when your period will ever come, and then it comes with a vengeance. So what are the common causes of abnormal bleeding? We divide those into structural problems and non-structural. And what does that mean? So structural means a growth or change in the muscle or lining of the uterus. And this would be things such as polyps that can be in the uterus or cervix, adenomyosis, which is a kind of like endometriosis or cyst of the uterine muscle. And this can cause very poor squeezing function of the uterine muscle and can lead to bleeding issues. Leiomyomas, which is really a fancy word for non-cancerous fibroid tumors. These can grow and cause the uterus to stop bleeding very well, so it just doesn't contract well. But other things such as endometrial hyperplasia and carcinoma, these are precancer or cancerous changes of the uterine lining. But the next category is non-structural. These are blood or hormonal problems. And these are things such as coagulation disorders. This is a poor clotting and you just flow blood. But there's also ovulatory dysfunction. And this is when you don't ovulate very well, very much like polycystic ovarian syndrome does. So now that you understand what causes bleeding issues, what are some of the things that doctors can do to find out what is wrong? Well, they will typically do a medical history. They're going to want to know the date of your very first period and the last period you had, but also your bleeding pattern, and they want to know the severity of bleeding. Do you have large clots, or you just flood with little clotting? They'll want to know, do you have pain? How much, and how do you treat it, and what do you use when you treat it? Generally, we're going to ask you things such as your medical problems, your surgical history, and also medications you use. Signs of bleeding disorders such as do you bruise badly or bleed easily when cut? Also, we're going to do a physical exam. Just a general assessment, pap smear we might do, external internal assessment of the vaginal area. And we might do what's called a bimanual examination where we feel the uterus and the ovaries. We may do labs. And what's the number one? Pregnancy test. So that's very important to always rule that out. Or if you're pregnant, to deal with those issues. But also a CBC, and this is a blood count to look at your platelets, which are the things that help you stop bleeding, and see if you're also anemic, and then you might need even some iron. We might look at TSH and prolactin. They're brain hormones that control the thyroid and ovulation, and they can really point to problems that interfere with regular periods and cause delays in your ovulation. We may also test for chlamydia. That's very common. We're supposed to do that anyway. And STDs can sometimes cause bleeding issues. But lab assessment for free bleeding is often done by a consultation with a hematologist, and they may look for things such as von Willebrand's disease, factor VIII deficiencies, and other blood clotting factors, but often a hematologist will do that for us. But the next thing we may do is a vaginal ultrasound. So if there is an enlarged uterus on examination or persistent symptoms despite us doing everything we can for you medically, we may consider doing an ultrasound. But an MRI also can be done, but it's really a last resort. But it can guide the treatment of both fibroid tumors and the diagnosis of adenomyosis that we talked about earlier. Tissue sampling, such as endometrial biopsy in an office test for removing a small amount of uterine lining tissue. So this is typically done as first line in women that are over the age of 45. Also, if you're obese and have a long history of irregular menses, that would increase risk for precancerous or cancerous changes, we can do an endometrial biopsy. It's about 82% effective, but if it's negative, about a less than 1% chance that you would have cancer. So that's very good. But if we can't do that, hysteroscopy in the office is where we can look in the uterus with a lighted scope. So again, it's called hysteroscopy. So we can go into the operating room for this as well and do what's called a hysteroscopy and DNC. And this is really, again, if we're unable to get an adequate sampling by office biopsy. Now, this has about a 97% success rate of getting you a diagnosis of what's causing your problem. So if you like the video so far, hit the like button. I hear that it really helps with the YouTube algorithms. And please subscribe, because God forbid if you miss any of my new medical videos coming out every week. I need you here. It keeps me going, and I want to help you. So back to the information you want. What are the most common causes of abnormal bleeding in different age groups? So we'll break this down into age groups: 13 to 18, so young, 19 to 39, and then 40 plus. So in that 13 to 18-year-old age group, persistent poor ovulation due to immature function of the hypothalamic pituitary ovarian axis. Yeah, I just said that, didn't I? But in plain language, this means that the brain hormones are not controlling the ovaries very well yet. The system just hasn't figured it out. But it eventually will. It just takes longer for some young women than others. So contraceptives can also cause some irregular bleeding. And it's not only that can be used to help bleeding, they can also cause it as well. So we look for that. Pregnancy and pelvic infections have to be considered if you're sexually active. And abnormal blood disorders should also always be considered if you've had to be hospitalized for heavy bleeding problems. But rarely tumors cause problems in this age group, so not very often. So in that 19 to 39-year-old group, pregnancy, number one reason for irregular bleeding and heavy bleeding. So we need to rule that out. But we also need to rule out fibroids, polyps of the cervix and uterus, poor ovulation often due to polycystic ovarian syndrome, but can even be diagnosed earlier in life as well. Contraceptives, again, can cause irregular bleeding. And now we get into endometrial hyperplasia, which is precancerous changes of the uterine lining. And cancer is not very common in this age group, but it's possible. So now in the 40 to menopausal years, poor ovulation due to declining function of the ovaries. So as we have poor ovulatory function, Now it's due to menopausal changes, but also that endometrial hyperplasia or precancerous changes, endometrial cancer, cancer of the uterine lining, also atrophy, which is thinning of the vaginal and uterine tissues, can cause bleeding. But also now fibroids are much more common in this age group. Well, if you guys didn't know, we recently went through a pandemic called COVID. What would a talk be without talking about COVID-19, as well as the COVID vaccines, but also how they may be associated with menstrual abnormalities? Recent studies show minimal effects on the cycle length. It does not affect it in any significant manner. One study said a 0.71 cycle day increase, which goes back to normal over time. They didn't specifically state that. But there may also be some increase in bleeding, but that also appears to be limited. But that is what the studies show. What you may have experienced may be different than that, and please let me know in the comments below. At this point, you may say, all this is fine and dandy, Dr. Jeff. You have told us what could be causing my problems, but how do I get better? Well, that is where we're going now. What are the treatments of abnormal uterine bleeding? Well, it's always based upon that whole workup you had and the diagnosis you ultimately get. If you're less than 45, and if it's really determined that you have very little risk for precancer or cancer or any abnormal structures, then treatment with hormones is the most appropriate way to treat your problems. And I most often use a medication called norethindrone acetate, which was also known as Agestin, and medroxyprogesterone, which is known as Provera. These are progesterone hormones that can be used for menstrual medical suppression, so you can safely have no periods. How about that? But there is also drospirenone. This is a newer anti-testosterone type progesterone contraceptive that can be used by itself or in combination with estrogen. But it's commonly used if you cannot take estrogen and progesterone, normal birth control pills. And all three above can be done that way. Oral contraceptives, which can treat irregular bleeding, also can be used. Progesterone-releasing IUDs can diminish periods because they thin the uterine lining. NSAIDs, Motrin, and naproxen. So NSAIDs, non-steroidal anti-inflammatory drugs, they can actually be used to decrease inflammation, which can help decrease bleeding. They can work fairly well, especially in younger women who don't want to really be on birth control pills. And they can also be used independently with other hormones as well. And maybe you don't want to take hormones at all. Well, tranexamic acid, was also known as Lysteta, is a medication that works by blocking the breakdown of blood clots. This causes your blood to stay clotted and prevent more bleeding. Most people do not have any side effects when taking tranexamic acid, but you can have nausea or diarrhea. Don't take it if you think you are pregnant or if you have a history of blood clots in your legs or lungs. And it shouldn't be taken when you're at the same day you're taking birth control pills. Despite this, it can be very effective in decreasing heavy periods even without hormones. So now, if you are at higher risk, such as being over the age of 45, you're obese, or you might even have polycystic ovarian syndrome problems, you could have an increased risk for cancer. So you must have a complete diagnosis with endometrial biopsy, and I feel ultrasound is very important to rule out tumors as well in this situation. But surgical therapy is also very possible if you have those structural abnormalities such as fibroids or polyps. Hormonal contraceptive management is also used in these situations, as I discussed above in the less than 40 group. But the next thing that is very common and can be used is endometrial ablation. It's the most commonly used form is NovaSure ablation, and it is a 90-second cauterization of the uterine lining under typically local anesthesia or general anesthesia. It's really kind of controversial to use this technique in polycystic ovarian syndrome patients, but otherwise it can be very helpful in decreasing or eliminating heavy bleeding, but in the right situation. Last but not least, as you were probably waiting for, hysterectomy. So I consider this really to be the last resort treatment, but it certainly is always a viable option. And this option should be discussed with your doctor if all other treatments have been tried, or maybe if these options are not right for you. So the main thing is, don't suffer. Get help from your gynecologist. They have the expertise to help you. And hopefully you feel you learned something. And as always, I've enjoyed being here with you. I love to help solve your problems at Women's Healthcare Answers. Remember, this video is meant for information purposes only. Please consult your own healthcare provider, but it is okay to reference the information I gave you.